This is United Medical ACO weekly event, and my name is Kemal Erkan. I'm the chairman of United Medical ACO. Good afternoon. This is United Medical ACO. My name is Kemal Erkan. Today is June 11th, 2021. This is our Friday event. As usual, we are here with you and we are going to share some updates from COVID-19 vaccination, the process that we are going through, some updates from the other side of the healthcare issues that we are having, or we are dealing with, and we are hoping that you would find this useful. Now, I'm going to go ahead and, before I actually share my screen, if Tanner can join me and then can introduce himself, and he puts a lot of time and effort to these with me, and unless I have his help, it would be difficult to be doing this every day, every week. All right.
Thanks, Kemal. As Kemal mentioned, my name is Tanner Fuchs. I'm a member of the business development team here with United Medical. So I help support our leadership team, the ACO, and our directors and providers and their offices directly on a day-to-day basis.
Thank you, Tanner. And I'm going to go ahead and share the screen. Let's see. We are going to do the fancy PowerPoint one. When I say fancy, I meant advanced. Okay, and here we go. All right, so hopefully this is visible and everyone can see it okay. And now we have, as I mentioned, we have some updates. Most of you are already familiar with this, and so one of my friends got the event update and then telling me that she was vaccinated. Very good. Nephews are checked, so they are watching it on their phones. Susan Anderson is already logging and watching, so that's good. The core team is already there. Thank you. All right, now from United Medical side, we don't want to waste too much time, but most of you already know what United Medical does. But we are the turnkey healthcare solution for healthcare industry, and that's the main thing that you should know. The rest is available through our website and other events that we have done. So Tanner is going to give me updates, give us updates on the vaccination, where we are so far.
Yeah, sure. So we want to start off with locally here in Delaware. We keep an eye on the percent of the Delaware population that is vaccinated, and we have pushed over that 50% mark. That's what we're seeing up here in the top left. That green line is going to show us the percent.
I'm going to just stop for a second, because on this one, the slideshow does not show the animations.
Okay. Yeah, I thought that they were on this slide. I wasn't sure though.
So let me actually stop sharing, and I'm going to just share the PowerPoint, so that way we have some good animations today, right? So
yeah, we have a lot in order.
Yeah. So all right, go ahead.
Sure. Yeah, thank you. So just what we're seeing here again is keeping an eye on the percent of the population that's vaccinated here in the state of Delaware, and then how that is pushing down the daily case rate. So up top here, we see we are just almost to 52% of the state of Delaware, and that is continuing to knock down the 7-day average of cases. And we're seeing that reflected nationally as well, which we'll get to here in a second. So aside from Delaware, we also want to take a look at the vaccination rate as a whole here in the United States. So Currently, we're a little bit above that 1 million doses per day mark, again, which is good news. You can see that uptick there as of late. But you'll notice here that we are on pace with that rate to reach the 75% herd immunity in another 5 months. So that's what's important here, is another 5 months. You may remember that as we give these updates, like late in March, early April, we were seeing that down to about 3 months to reach 75% of the population covered. You might remember, though, that was anywhere in between the 3 to 4 million at its peak doses per day. So now what this is saying is, at our rate of just over 1 million, it is going to take another 5 months to get to that point. So where we are initially were projecting to reach that 75% herd immunity mark here in late June, early July, middle of the summer, this is saying if we are to maintain this rate of just about 1 million or slightly under, we're kind of varying between right under 1 million to slightly over 1 million. This is going to take us another 5 months to still reach that 75% and get that additional 25% or so of population vaccinated. And that puts us right around the November Thanksgiving time. So I think that is important to note, as it does show the importance of a continued vaccination effort.
So, Tanner, this is really important for us, right? So we had a providers meeting last night, and we were discussing this. And one of my issues with this one is we have to take some ownership. People have to take some ownership. So I do actually, let's go ahead and finish your update on this slide, so then I will tell you how I feel about this whole thing.
Sure, yeah. And we just wanted to touch on where the United States was as well with the percent of people getting vaccinated, which does tie back into that continued vaccination effort as we push towards 75%. So you'll notice the United States as a whole is just under 50%, pushing that 48% of the population being vaccinated. So Delaware is slightly above the national average. And the other important thing here I just wanted to note is the continued push downward of the daily case, or the 7-day average of cases in the United States as a whole. So now that we are, something important I think is, now that we are a few weeks out from the Memorial Day weekend, we should start to, in the past, this is when we would start to see the increase in cases, but we're not seeing that spike, which is good. Like we did see with early on, whether it had been like the holidays, the end of, or throughout the winter, we're not necessarily seeing that here with Memorial Day.
So, well, okay. So what happens today, this is my second Friday that I'm at home. Actually, I was told to stay home because we have some furniture work that's being done in the office. So there's a little bit extra noise. But of course, Ann Wilson forgot that I have another noise factor here. So Dr. Buddy is, not only he's kind of like old and making different noises, but he also barks, as you can see. That's what you were hearing, and I apologize for that, but he needed to go out. So now let's go back to this issue of 5 months from now, the vaccine and the ownership on everyone. So we can expect only so much from the government. We individuals have responsibilities. We are not just going to be told by the government or just ask government to force us to do stuff. We'll just do the right thing. And if this is the right thing that you believe in, you need to go and get vaccinated. I'm not saying that everyone has to be or must be vaccinated. I understand if there are other people who definitely don't want to do the vaccine. But if there are no objection, and if you are willing to do the vaccination, you don't want to be too late. Now, Tanner, you remember this is our second year with the COVID-19, and if you remember what we discussed, those times our meetings with our providers was daily. And one of the issues that we were talking about is summertime coming in, everyone is kind of relaxing a little bit more. Of course, this summer makes it less severe, so we don't actually have the same seasonal issues. And then people forget about the winter, and winter is coming, and we'll be back. So we want to be prepared. So 75%, if this is a good number for us, we want to be at the 75% level before it's too late. That still gives us that 25% who don't want to do vaccination. That's perfectly fine. We are not saying that. And I did early on, I was maybe a little bit harsh on people who didn't want to get vaccinated. I'll change my position a little bit, saying that there are enough people who can get us through this without having everyone. So if 75% is the right number, let's just go through with the 75%. But my concern is that timeline is being pushed further every time I have these updates. And hopefully our people are understanding what we are talking about.
Agree. Yeah, I think that's a really good point. As like you mentioned, we saw last winter with the incredible spike of cases then in those cold winter months. So although there may be a lot of people who think that we are, as we're getting closer to 50 and plus percent, and we are seeing cases drop, that might just be a good enough excuse not to. But that 75% is certainly a mark that we want to reach for a reason. And it's going to be important over the next few months that we are able to accomplish that.
Absolutely. All right. So now let's go back. We have some other updates.
We wanted to get into some other updates, some things that we are seeing in the news, and start off with one related to the vaccines. And this in particular is about the Moderna request for emergency authorization from the FDA for that pediatric 12 to 17 population that we saw with Pfizer. So they formally did submit that request to the FDA yesterday on Thursday. So this is going to be expected to be our second vaccine for that population, which is going to be good in getting, of course, more and more shots into arms, more population of our population vaccinated against the virus. So as you may remember, Moderna was one of the first, or I believe the second, that was authorized for adult use back in December. And their clinical trials for this pediatric population showed, similar to the Pfizer vaccine, 100% efficacy rate in their population, which looks like it was about 3,700 children from 12 to 17 were tested or used in the vaccine for the clinical trial. And it seems the numbers are pretty similar to, if not exactly similar to, the Pfizer vaccine that is already approved. So we can expect this to be approved as well by the FDA. And more than likely being used here in the next month or so.
This is very good news. Now we're going to talk about our next item, and it's hard to believe probably when I say this, but I'm a little bit older than Tanner. So why I say this, because when you get older, when you are more mature, then you stop thinking about what other people think of what you do. However, I still give a heads up, so or a little warning, so that you know what we are presenting, what we are about to present. We don't have any political motivation. It's all about healthcare now, and we are objective, and we'll discuss everything and everyone. We'll bring up every issue. That's not a problem. So, and sometimes we may actually contradict ourselves from one week to the next, because there may be something new coming up, and maybe we have some new information. So it's fine when we are maybe putting this in a different way. So what I'm about to say is, we want to actually just look into the Dr. Fauci situation. Now, if you are following these events, you probably heard me saying that I support Dr. Fauci a lot, and there was a time that I said, well, I'm actually questioning his position. Since then, so I was on both sides of Dr. Fauci. Now, since then, we had these emails actually went out. It was for March and April 2020, all the email correspondence that he had was shared with public. Now, so 50 Shades of Dr. Fauci is I think what we are dealing with. So we need to understand, and actually I got a little argument with Anthony Anugu at the providers meeting, and I challenged him, or he was challenging me, but I have a pretty strong point on this issue. If Dr. Fauci was working for me, I would have terminated him. Actually, I would ask him to resign probably, or retire. So his day job is, he is the director of U.S. National Institute of Allergy and Infection Disease, NIH, and he's also the advisor now with the 7 presidents. Now, we have seen him in so many different ways. Was he the hero? Was he the guy who was in trouble, or the guy who puts us in trouble? What's his position? What we expect from his position? All these are really important issues with Dr. Fauci. Now, I am not going to actually share the video, or at least I'm not going to play the video. But if you are watching the news, you'll see that he actually is making reference with the funding, the NIH funding labs in China. And you'll say, well, what's wrong with that? Well, what's wrong with that is the pandemic that we lived with in the last 18 months and then another maybe 12 months. So the issue that he had was the issue that we had. So he was saying that, well, do you want me to do human and animal interaction? Was it, Tanner? Like like if something is infected, if we can be infected by the animals, if that type of the study, do you want this to be in New Jersey or Virginia? Well, and I was actually trying to bring Tanner on board with this, and then we were not on the same page yesterday. And then he said, well, I said, well, we can do it in Nevada, we can do it in Texas. We have bigger places, less populated places. And then he said, well, we do nuclear test here, right?
I believe that's in Nevada. Yeah.
But the main thing that we have is we lost control. So when we were trying to put this outside of the United States, what needs to be understood is you also lose the control. You also lose the first-hand knowledge, so that you are not able to actually know. Now, this makes me think that what if China really knew that this was happening, and that's why they really have, if you assume that if their numbers are accurate, maybe that's why they were able to actually get this under control before everyone else.
Yeah, I think you have to be really careful with those types of what if situations, just certainly because just from what we know as of now, most of the decisions made early on were being driven from what information was available and scientifically available at the time. So kind of going through everything that is being coming out now, it's certainly important to make sure we're getting like the information from reputable sources, reputable places of information when it comes to what was known, when was known, and then what actions were being taken. So it's certainly something to kind of be to tread carefully with.
Mm-hmm. Well, no, we are careful. We are just going based on what we hear, right?
Correct.
So, the other thing that we made, another argument that we have with the requirements of this job, why does the 80-year-old have to work this way, for this position, for this kind of level of intense, demanding job, right? Mm-hmm. So, well, you have to question what the 80-year-old is going through. My dad is 80, and I mean, in some cases, he tells me about some of the issues that he's going through, and then he doesn't need to be working 12, 13 hours a day. So we actually kind of still like him. Not my dad, I'm talking about the Fachi. So, of course, we love my dad, but anyway, so that's something that I guess more is going to come out. But I think before, I think he should retire so that he's not being asked to step down, because I think the pressure is going to be there. Some of the videos that I shared with Tanner yesterday, I don't want to do it here because I don't like the demeanor of those videos, the sound of those videos, the way that they actually, the position that they take, the way that they present, because that's not what we do here. But when you hear it, even take like 40% off those, edges, it still is too strong. So,
Right.
all right. Well, so another update we have, Tanner, if you would like to give this update.
Yeah, I wanted to include this as well, as it's a good follow-up from those who were able to see our last session together when we had CEO of YWCA Delaware, Stephanie Statz, on to kind of just talk about what YWCA Delaware is, what they do, what their goal and their mission are for the community, and kind of talk about how recently United Medical has, or not just recently, but how United Medical has been involved with helping them achieve their goal and their vision. So we have a call to action letter here, and this is just something we can do to show our support individually, as a group, and as a community for YWCA Delaware. And there are requesting or asking just that we send a letter of support to the Joint Finance Committee requesting that they receive their full funding. So this is something I think is important for us to be sharing, certainly as we have a good network and a good community that when they're able to come together can certainly accomplish something like this.
So at our provider meeting last night, so we started with 38, and then we asked
right.
We asked them if they could actually just support us, and they did, and left the meeting with 50, but now the goal is 100. So hopefully everyone can support YWCA. YWCA is an amazing organization. It's one of the best kind of charity organization, and they can use more help from all of us. Now, we are going to discuss our next topic is when we got the news from Christiana and Highmark, Christiana Hospital and Highmark Insurance Company, the collaboration, we panicked a little bit. Why? Because we know too much. So that's why we probably panicked. Now, we know that hospitals are extremely costly. Large hospital systems are extremely powerful over insurance providers, and they can negotiate better deals by using their power. They are taking over practices, and well, from the personal business standpoint, I know several surgeons joined Christiana Hospital, and several primary care physicians I lost to Christiana Hospital, and we want that to stop. And then these systems can drive out the competition, which is another big problem that we have. And the hospital systems, they can grow into monopolies if they are not controlled better. So now you are going to say, why do we care? Well, here's our Delaware hospitals. It's not like 100 of them. We have only a handful. St. Francis is the unique situation that St. Francis has. It's the only hospital probably loses money in Delaware. And Bay Health Medical Center, Christiana Care, the Morris Children's Health System used to be formerly known as AI DuPont. BD and Nanticoke are a couple of the hospitals. Now, let me actually just draw, work on my artistic skills here. Now, this hospital here is in a partnership with this one for their accountable care organization. And they are also in a partnership with this one. And guess what? They're also in a partnership with this one. So now, this is the Children's Hospital. So nothing against the children, but I'm going to take it out of the equation for 1 second. So if you don't have the children, because of the Children's Hospital, so take them out. So there are 5 systems, and 4 of them are in a partnership in their ambulatory practices for accountable care organization called MSSP, Medicare Shared Savings. So this is a huge problem, not only for us, but for public. And I want to make sure that people understand this. Now, most people also don't understand that we have only 2 private insurances who can sell insurance policies in the state of Delaware. It's Highmark and Aetna. And Highmark is, I don't have the latest market share, but I believe it may be between 70 and 80%. It used to be when Tanner was in college, Highmark was 90% of the private sector. So now Aetna did some, they got the state of Delaware's employees and Christiana Hospital, so that probably changed. But now with this partnership with Highmark again, I think it's going to change. So now, one of the news updates that we actually put it in this section is the United Healthcare. I don't want you to confuse United Healthcare with United Medical. Although if I was their CEO, I would be extremely wealthy, but I'm not their CEO. So they came up with this news saying that we are not going to cover non-emergent. So it's really important because, well, let me actually stop sharing for a second. So I'm 47. When I got here to the US, I was 25. So I was a year older than Tanner's age today. So I lived in the state of Delaware for 22 years. For the entire time. I was a very loyal Delawarean. Most immigrants, they want to live in the big cities. I stayed here. So now, one of the things that I was going to say is that when the English is the second language for someone, we make a little bit more out of the language itself. So then we're more careful when we are reading. At least I am maybe more careful. So I read non-emergent in the urgent settings, what they're against, non-emergent in the urgent settings. So the initial reaction should have been, well, why is that happening anyway?
Right. That wasn't the case. Yep. And that kind of gets into the more, like you said, the more recent update. So just recently after that was had first come out, I believe it was supposed to start initially on July 1st, if I'm not mistaken. But after receiving certainly some backlash over the announcement, this is something that is going to be postponed. Is that correct?
Yeah. Now, it's a huge mistake, but it's going to happen, unfortunately, because the hospital lobbies are extremely powerful. Just lack of the term that I call them, it's almost like a legalized mafia. So they're so powerful that they can actually, just like what we want to share in this session, we pick and choose, right? Like, for example, when they were bashing Dr. Fauci, we didn't want to share that because I don't think that's our message. But if that's what I wanted you to hear, then I would play that. So media channels are controlled by these lobbies, and therefore they actually put this in a way that if the insurance company is doing something wrong. And if you look at all the newspapers, they're like, oh my God, the hospital is denying care. That is the biggest lie ever. So that's the biggest lie ever.
I think
sorry, Tanner, like what we discussed,
okay.
if you remember in the last couple of sessions, we talked about earache. So,
and
this is
right.
So,
and I think they said it would, as of looking at claims coming from hospital visits, it's going to be, or on average, it would have been about 1 in 10 visits. So again, it's not saying that they're going to be deeming every other hospital visit as non-emergent. It does boil down to those visits that, from the data that we've certainly been able to support with, those earache visits, the cough visits, those sort of preventable, non-emergent visits that these patients are coming into. And it comes back to tying back in, just making sure that these types of visits, patients are aware that these isn't the setting to necessarily have that taken.
So now,
that's what's important.
No, that's really important. Now, here's what I want people to also hear. One of my, I have several day job businesses, responsibilities, different hats that I'm wearing. So one of them is, one of my expertise is the hospitalist. So I was running the first hospitalist business in the state of Delaware. It used to be called Hospitalists of Delaware. I was with them for 5.5 years. And then in 2008, we started working with Christiana Medical Group as a hospitalist. With them, we set up with I was the CEO and president of that group. And we have St. Francis Hospitals we started. Then we started Bay Health Hospitalists. And then that was until 2011, 2012 timeframe. And then in 2011, we also started Surgeons for Emergency Care. It's, in a way, it's a surgical hospitalist. Now, why am I telling you what I did? Because it's relevant for this. So during the 6 years of Surgeons for Emergency Care, we work with all hospital systems. Now, many of you may not know, which you will find out. And I didn't know this until I got in that business. So our goal was with Surgeons for Emergency Care. I have 15 surgeons from 7 different groups. So, Tanner, I don't know if I mentioned this too, but I started the book writing process, and Surgeons for Emergency Care is one of the first chapters. It's a little bit fresh in my mind. So, and it's so important for what we are discussing. So 7 different groups, 15 surgeons, we put them in one group for their on-call schedule. So I changed their on-call responsibility from on-call to on-site. Now imagine that there were some doctors who were in their mid-60s, and they never have done the on-site since they were residents. Now they went back to the on-site because there was an economy of scale where you have 15 of them are doing the same thing. So all 7 groups are doing it at the same time. You can actually reduce the number of calls that everyone is doing, but then in return, you ask them to do this on site, which that's what we did. And it was working perfectly, but then what our goals was, we wanted to actually not wait.
I'm sorry to interrupt. I think there might be some audio issues going on. Your mic all of a sudden got kind of, it sounds like the voice is vibrating.
Okay, so let me turn it on and off. Is it any different now?
Oh, yeah, that's a lot better.
Okay, I think it happens. Well, it does happen every once in a while. I don't know why it happens.
No explanation.
So I don't know where it started, but going back to the responsibilities of the surgeons. So then we worked with initially Christiana Hospital. So at that time they were running 20 ORs during the daytime. That's pretty big. So now, Tanner, 5 p.m., the 20 goes down to 10. And then at 11 p.m., the number of OR that they can staff goes down to 2. And then when you have only 2 OR available, and when you are one of the level 1 trauma center, then what's going to happen? You may be getting, and then plus we are the hospitals right on 95. They get a lot of trauma level type cases. So you will say that. So we were hoping that by being on site, we can actually expedite getting the surgeries on the emergency general surgeries earlier, on time, but then they said they cannot really give us the OR time after, especially after 11. So you have to wait until next morning. Now, and again, Tanner, I apologize in advance because I didn't tell you what I'm about to do, but I did this to Kosibi last night in the providers meeting. So being 24 and being a male, you are a high-risk candidate for appendix. So where do I know this? Is because of the surgical hospitals that I did.
Right.
So, and if you have the lower quadrant pain, like this is appendix is more common for male, younger male. So now, if God forbid, if you got this type of pain, and it's 6 p.m., you go to the hospital, named the Christiana Hospital. So you wouldn't get your surgery, this emergency surgery, until next morning, and as early as like 7 or 8 a.m. So
even with an appendix,
12 hours, 13 hours.
Which could be life-threatening if left untreated.
It is life-threatening, but they can stabilize it. Now, we are not talking about this. We want these types of things to be taken earlier by eliminating non-emergent cases. So Christiana, hospital systems and the ED doctors, they are used to getting this income because when we were actually talking to them initially in the ACO business, they didn't care if we were trying to reduce the number of ED utilization. They didn't have the collaboration with us. I went to all hospitals, and Donna Gunkel, maybe next couple of weeks, she may come back for us. She's off this week. And she and I, we had our meetings with all hospitals. The only one that had a meaningful collaboration was Nanticoke Hospital. Christiana, right out, they refused to actually even be part of it. So this is income. Now, let's go back to our main issue. So then this is a hospital file in a way. So if this was a news program, this is our hospital file. Now, the problem is, the issue that we have is there are so many unknowns that public doesn't know. And because of the name under nonprofit, as they're labeled nonprofit, it's interesting. One of my providers, who actually is employed by us, is sending me an email saying that, well, because we are for-profit, I don't know where she heard that from, but because we are for-profit, we ask her to see more than 15 patients. I'm like, where is this coming from? Like, you haven't seen more than 16 patients ever in your life. But then, if I was working for a nonprofit, I wouldn't get this pressure. Lie. That's the biggest lie. So, but she probably hears some of these discussions and not understanding what we are discussing. That's why I'm bringing this up. Not for profit doesn't mean that it's no profit. So I have shared this before with our audience, and what we need to understand is this label is extremely misleading. Now, Let's remember our Christiana Hospital operating room provided both inpatient and outpatient surgical procedures. 2010 to 2018, 10-11 fiscal year to 18-19 fiscal year. This not-for-profit or non-profit organization was able to manage to increase their 80 million profit. Okay, people, wake up. 80 million profit to 118 million. While their case number did reduce, and we discussed this, I believe Christian Scott explained this in maybe 3 or 4 weeks ago. Mm-hmm. But I think when we need to hear this again and again to understand how bad what we are discussing here, this hospital, they increased their profit, not revenue, not gross income. It's profit from 80 million to 118 million when they reduce their number of cases by 10%. Well, you know what? Congratulations, Christiana Hospital. You are a really good business. I should be doing that as a for-profit organization. But let's actually look at our 2 hospitals in Delaware. Okay, so that you understand why this person, me and Tanner, we are talking about this and why this is important. Of course, it's affecting our business, but it's more than that. It's affecting our people in Delaware. Christiana Hospital's 2018 net gain, net profit is 200 million. So, Tanner, I don't know if I told you, but there was one employee in the old days that he quit because I wanted him to post this. And he said, oh, I can't do that against Christiana Hospital. They are like the nonprofit organization. I'm like, I'm telling you to post their 200 million profit, and he couldn't do it. So, but Bay Health is not different. Bay Health it's a smaller hospital. Well, Christiana made this 200 million out of revenue of 2.1 billion, okay? But Bay Health is not that bad either. They were able to make 59 million. And that's from 695 million. That's for profit. Now people, 2 Delaware hospitals, 260 million profit in 1 year. So please stop, telling others that, oh, these for-profit organizations, because now not only we are saying this, but also there are some people with common sense in this medical field, and Christopher Cheney's article from 2016 explains the differences between not-for-profit hospitals and for-profit hospitals, and there isn't any difference. In fact, it's surprisingly close, or for-profit hospitals are doing either better on quality or either better on charity and what they are giving to the society. So why am I sharing this is because, the perception is everything. And the hospitals under the label of not-for-profit, they are able to get more out of our state government and our federal government. And we want this to stop. And I had several meetings these couple of months. We met with our Congresswoman Lisa Blunt Rochester. We met our governor. I had a meeting with him last Tuesday night. I had a meeting with the Department of Justice. I had several meetings with Tanner from our sessions with Brian Townsend, David Bent, and we'll have more meetings coming up. We are going to keep this up and we are going to be loud because this is affecting everyone. There are some more stuff with this, but I think main point that we want to make is, which actually my article will come out and you can kind of read in more details. But there are two articles that came from a couple of these individuals. Let me actually just go back for a second. Unless we read, we won't learn. Knowledge is everything. Access is power. So, and that is, let me take this. So this is kind of like interesting. This is Dr. Kristen Dickerson, one of the articles that I read several months ago. When it's about the transparency, it simply does not exist. That's why now tie these all back to the United Healthcare's non-emergent to urgent in the emergency setting issue. And then what you'll understand is these profits from the hospital systems are made over people. So you pay for it, we pay for it, and then we want this to stop. Local community and American taxpayers who end up footing the bill. That's from, I just want to give the credit to Dr. Dickerson, but that is not, I can't say that in any better way. The local community and American taxpayers are paying the bill. So my goal and our goal is to make our public, increase our public awareness on these. Don't go to the hospitals if you are not having an emergency situation. If you are able to drive on your own to the hospital ED, call your primary care physician's office, call your insurance companies. They have a nurse online available, do a triage. When, this morning, and I was, and he probably knew that I was going to be very happy, not with what he shared, but because he shared that this is one of our managers, Carlos. Last night we discussed the hospital wait time, and then usually St. Francis Hospital is extremely low. And they have a billboard on 95. And this morning, I think, and I don't know what he was doing, it was 7:27 in the morning. It says on the billboard 99 minutes. So when you go to ED, you know that you are going to wait minimum 99 minutes, even at the lowest wait time of place like St. Francis. If 99 minutes at St. Francis, that's 4 or 5 hours at Christiana Hospital or Bay Health. So call your primary care, call your insurance company nurse line, get your issue triage, and then help you and help us. This is not just for today, this is long term. And I believe we have to really take the ownership on these issues. So Tanner, I don't know if, I know I had to cut through some of the slides a little bit quick, but that's all we have for today. I don't know if you want to add anything.
No, I think that that's really important, especially going forward. As you mentioned, these problems are existing in the community, and it's not just affecting, it might sound like going over and over again, that this has really no motivation other than it's for our community, for our patients. And these are things that we're going to continue to discuss. And as you've mentioned, even with some of the other events we do, if the more we go over these, you're going to learn something new every time. You're going to maybe catch something that you were unaware of previously. And I think that these are good discussions to have going forward. And it's good that we're taking the time to go over these things.
Sure. And, just to close it on a good note, I think this is a really important
yeah, this was something that we wanted to go over.
Right. So this is our patient survey shout out. So Tanner put this together for us. Tanner,
this was
the traffic of the surveys. If we have any negative outcome, you communicate that the providers' offices with their managers and with patients and you put this together. If you can just explain what we are looking at right now.
Well, firstly, I think this was actually Nicole from with UMC. She's been doing a great job with a lot of the outreach and the social media communications coming from the clinic. But that is correct that these surveys do go out on a regular basis to our patients. If you have the IQ Health portal, I'm sending them directly to your IQ Health portal. And it's really important to be able to capture the patient experience, make sure that they have their feedback is going to be important to us to not only grow as a clinic, but also to make sure we are providing the best possible care, the best, highest quality of care. So when patients are receiving these communications, we're getting this feedback directly to the practice, to the administrators, to the office managers, and to the providers, so that way they're aware of how their patients are feeling and what can be done to just improve upon the patient experience.
Well, thank you so much, Tanner, for the update. So this is what we have for today. We have our bariatric event in 5 minutes. Dr. Isaiah Ergan will be with me. We'll discuss some of the issues with the bariatric surgery patients' experiences. So if you have time, please join us in 5 minutes on the same channel. And we hope to see you soon. If we don't see you at the next session, we'll see you next week. Thank you so much. Bye-bye.